Looks like everyone's settled in. So I just wanted to start today by thanking our guests again for last night and just letting you guys know that I'm in the process of making sure we can reach out to all of them and share their contact information. So you'll be getting that soon. The recordings of all of those breakouts from the mixer last night will be available on Monday. We'll probably link to them on the video page of the portal. Still a couple stragglers in terms of the evaluation for the first part. You're going to evaluate it again on Friday, so I'd really appreciate the few of you who haven't finished the evaluation to weigh in. I stress that because we really use your input and improve things, so please finish it off. Nell just put it in the chat. And I just wanted to thank our funder one more time. The Retirement Research Foundation for Aging has been an incredible partner, and in this topic in particular, because they have identified a lot of people working in this space. So many thanks to the RRF. And with that, I'd like to pass to Carol Heimowitz, our moderator this morning, and our two wonderful panelists. Carol, over to you.
Hi, it's great to be here for this important topic in this conference. I know you've been discussing so much about housing and lack of housing. So I want to introduce our panelists so that we can get going quickly. There's a lot to say about how to stay at home. What do we need to build to keep people at home? With us is Sarah Santon, who is Dean and an endowed professor at the Johns Hopkins School of Nursing, and Cheney Fabius, Assistant Professor of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Sarah is going to start us out talking about her innovations in the field of keeping people at home and what's needed. So Sarah, go ahead.
Great, thank you. And thank you. It's wonderful to be part of such a great program. So I'm sorry, I'm a nurse, now I'm a dean, but I'm a nurse practitioner with a PhD. And my practice initially was with older adults who were homebound. So people who either were completely unable to leave home or it was very, very difficult. And so I was on the faculty at Johns Hopkins when my clinical practice was 2 days a week, was seeing people who were low income and unable to leave their home. And I went thinking about their diabetes or their heart disease or their, maybe their swollen ankles from their congestive heart failure. But I would be greeted by, someone who needed to drop the keys from the second floor window down to me to find in the grass, for example, because they couldn't get down their stairs and they'd been upstairs for years, literally. Or someone who would answer the door and I would not see anyone. I would look down and they would be on their hands and knees, and that's how they got around their house. And there were just multiple situations where their ability to move around and take care of themselves and bathe and dress were so much more important to them than what their hemoglobin A1C was or their blood pressure, as it would be to any of us here. And I was there kind of addressing the wrong thing in a way. So together with others, together with Laura Gitlin, we co-developed something called the Capable Program, which involves a nurse, an occupational therapist, and a handy worker, with the idea, as you all know, in aging, it's all about the fit between what a person can do and what their environment requires of them. So if someone's got holes throughout their floor, that would be, an issue for any of us on this call. But if you've got, a shuffling gait and some lack of balance and maybe some brittle bones, it can lead you to sit in a chair all day, or it can lead to falls. As one example. And Capable went from kind of crazy idea where, as I was sort of shopping it around to people that thought, you can't, a handy worker, NIH will never pay for handy work there, that's ridiculous, to now it's in the geriatrics textbooks. If you look in Up to Date, which is what doctors and nurse practitioners look in, under disability for older adults, it's one of the treatment options, and it's in 23 states and 45 sites. 3 states are working it into their Medicaid programs. So in a way, that's a huge success because it's only been about 15 years since we had the idea and piloted it, but it's only reached about 10,000 older adults. And there's about 13 million, we figure, based on national data in terms of who's got some difficulty moving around or, doing some of their self-care, who could benefit from it. So it's in this funny place of, leading edge, and should be standard of care, and yet almost no one gets it. I'll just tell you also, I know you've heard from Habitat for Humanity. Habitat for Humanity are often key partners in capable programs around the country. And when they offer it, they do more than the traditional handy worker stuff that Incapable we have. So there's 4 nurse visits, 6 occupational therapist visits, and $1,300 of home repair or modifications or assistive devices or everyday items like a lighter vacuum cleaner, for example. When Habitat does it, they tend to spend more, up to $8,000, because they'll also, work on a roof or do a boiler or other things that are more specifically about the house. They do more with ramps than we do, for example. Incapable, on the average work order that the older adult prepares with the occupational therapist is about for 14 things. So it's not nothing, but they tend to be small things. A doorbell. You'd be surprised how many older adults live with their doors unlocked because they're scared that the EMS won't be able to get in, or, so something with their door lock, and something, a reacher to grab things, and a heating pad that's weighted, that feels like wet heat, or, it's a lot of small things, some to the home and some that are more specifically for the person. We've had multiple randomized controlled trials. It's been tested in urban areas, in trailer parks, in rural areas, in micropolitan, and it's all, the results are so often the same that I started to worry maybe there was a problem with the data, but what it is that it's completely adapted around an older adult's goals. It has nothing to do with what the clinician wants. So if you look at the goals that people develop in Capable, for someone, it's being able to walk to the mailbox. And for somebody else, it's that they want to get out the back step to listen to the birds. And these are non-medical goals. They are to be able to bathe safely so their grandson doesn't have to come over and pull them up out of the bath, which is horrifying to both of them. It's these non-medical goals that then lead to more self-efficacy, more strength. The things that we do to the house also serve as environmental cues for new habits. So if someone, for example, has a grab bar that fits under their mattress, when they wake up in the night, they'll see it and they'll remember, oh, I'm going to sit here for 30 seconds before I stand up so that I'm less likely to fall going forward. So that serves 2 purposes. One, it helps stabilize them, and the other, it reminds them. So it's been tested over and over. It saves about 7 to 10 times what it costs. That's been replicated over and over in terms of decreasing nursing home admission and hospitalization. It also decreases specialty care. The only thing it increases, which we think is appropriate, is it increases home care, so that there may be referrals for home PT or home OT that is not what's part of Capable. It's a different kind of OT. So that's the gist of Capable. I do want to say that I know that Carol and others have been using like stay at home or age at home or age in place. And we've really moved to talking about aging in community because not everyone wants to age in their particular home. They want to age not in a nursing home usually. And I think also aging in place sounds a little stuck, like we're in concrete, we're in place, when really we want people to be in places. We want people to be able to volunteer at the local school and advise a small business and take care of foster kids and do all the things that we know that older adults can and want to do. So since you're journalists, I just want to put out there, I much prefer a term like aging in community or aging with independence and dignity. Although, some people don't really call out that for some cultures, independence is what people want. And for other cultures, that's not the right term, that we're all interdependent all the time. So that, focusing on the dignity and using people's strengths matters. So I think I'll leave it there and be happy to answer any questions.
Thank you, Sarah. And we're going to move right now to Cheney, who's going to give an overview of some of her work, which involves a lot of analysis of funding for home care. Go ahead, Cheney.
Good morning. I was getting ready to say good afternoon, but good morning. Thank you all for inviting me to share. This is really an area that I am passionate about. I approach my work through the lens of a former family caregiver of grandparents and parent, and current long distance family caregiver. My caregiving roles have changed tremendously now that I have small children, but a caregiver nonetheless. And then also as a former care manager for older adults for the Connecticut Home Care Program for Elders, which is where I'm from. And so as a care manager, I helped set up home care services, so home community-based services, as well as helped transition Medicaid enrolled older adults back into the community with home care services after a long stay in a nursing home or an institution. So that was part of the Money Follows the Person program. I observed as a care manager some racial and ethnic differences and preferences for care, what people could access, and that really made me want to have a larger impact than I felt I could have in my role at that time. And so I began to do work and research, and so most of my work or my earlier work, I'll say, a lot of it just described differences in home care settings by race. And so looking at what people are receiving, where they were living, and things like that. And since that time, I've continued to do some of that descriptive work, but now I focus a lot on interventions that might benefit and strengthen the relationship between older adults, family caregivers, and the direct care workforce, especially in Medicaid, home and community-based services. And so I just want to, I thought I could use the time to sort of give an overview of the who, what, where, when, how type of thing with HCBS, and then also talk a little bit about some of the disparities that we see in home care, as well as some of the recommendations that people have made. So HCBS, we know, are designed to support independence and quality of life for people with disabilities, and as Sarah has said, in a community setting of their choice, right? So it's not always a traditional or where their home is, but in a setting of their choice. But they do aim to delay or replace the need for home care, for nursing home care. They can be provided in a traditional home setting, whether you live alone or with somebody else. They can be provided in residential care settings such as assisted living. And assisted living is oftentimes considered a community setting, although assisted living is very expensive. It's often paid for privately. And I think in 2021, I was just looking up this morning to prepare for today, I think the median cost of assisted living in 2021 was like $54,000 a year. And so it is often paid for privately. You can imagine that has tremendous impacts on accessibility for people. But over the last few years, Medicaid waivers have also been allowed people to access assisted living services. And so we do see an increase in those who are Medicaid, enrolled in Medicaid. Home care services often include personal care to help with bathing and dressing or toileting, homemaking services that help with laundry, shopping, some of what we understand to be instrumental activities of daily living. Transportation can also include home delivered meals like Meals on Wheels, as well as services to help to attend adult day centers. Individuals, like I said, or families may pay privately, but much like assisted living, home care services are expensive. And so homemaker services in 2021 cost $59,000 annually. Home health aid services, $61,000. So they are quite expensive, but oftentimes they are delivered via Medicaid, home and community-based service waivers or state plans that states offer. States have discretion on who can receive or access waivers. So they may often restrict a waiver's accessibility to a geographic area in the state or a certain population of people within the state, but that is typically how people are receiving services. And people who receive services via the waivers are usually and oftentimes living with a level of disability that would qualify them for a nursing home stay. So we're talking about people who otherwise could be in a nursing home. Medicare home health also gets lumped in with home care services. It is traditionally a post-acute service, but over the past few years, we've seen an uptick in people who are initiating services from the community rather than it being referred to following a hospitalization. So we still consider it as something that supports people in the community. And as a result of rebalancing efforts, so the efforts of states to redirect their home care finance or their long-term services and supports dollars from institutions to home care, we have seen a shift, right? And so, for example, 20, 30 years ago, only a small portion of Medicaid long-term service and supports dollars were going towards home care. Now more than half. Nationally. And so there has been a shift. So the people that provide home care or HCBS are part of the direct care workforce that consists of home care workers that might include personal care aides, home health aides, nursing assistants, residential care aides that provide assistance in assisted living settings, and then nursing assistance. And the thing I'll say about the direct care workforce is that they are a high demand workforce, but they are often undervalued and underpaid. The annual or the median hourly wage for this group in 2020 was $12.98. I also want to put a plug in for family caregivers. I'm getting the red light, so I want to put a plug in for family caregivers. Just to say that they are a big part of the puzzle, right? We talk about the direct care workforce, but they are a big part of the puzzle. And then the only thing that I'll say about racial and ethnic disparities, and I'm happy to talk about this more during the discussion, is that the findings are mixed, right? I can talk about the limitations in data and things like that, but the findings are mixed. But we do know that there are disparities, for example, in accessibility. We know that there are disparities in what people receive. We know that there are disparities, racial and ethnic disparities, in the amount of services that people are receiving. And so there are several recommendations that have been made to support both the direct care workforce and the strengthening of home and community-based services. But I will stop there and happy to talk more about it during the question and answer period.
Thank you. We're going to have a little back and forth discussion before we open this up to general discussion with all of you. I wonder if, Sarah, you can start us off talking a little bit, answer the question of what is it going to take to ramp up a program like Capable? Why hasn't it ramped up already?
Well, I would say, don't get me started. So if Capable were a drug, it would be a blockbuster, right? It cuts, disability in half pretty much, and people's ability to participate in community makes it so much easier, and it saves costs. And so if it were a drug, we'd have the FDA pathway, right? So we would show the results that are verified, that are peer reviewed, and they would look at them, and then they would say, okay, this is approved, and then doctors and nurse practitioners could prescribe it, unless it's one of those crazily expensive Alzheimer's drugs that don't seem to work. But with things like services, there's no equivalent pathway where you show that, and it shouldn't have to save money, right? Hepatitis drugs don't save money. They just help people's livers, and and heart valves don't save money, but we hold the services to a higher standard, that it has to be a win in all the ways. But Capable is one of those rare ones where it is a win in all the ways, and financially, and for families, and for older adults, and for society, and clinicians. Clinicians love providing Capable because they see how people change. But one of the ways we were tested was through the CMS innovations process, which you all probably know that was part of the Affordable Care Act. And in it said that if the CMMI tests anything that saves money and improves lives, or does one or the other without detriment of other, it could scale whatever it funded. And so that we were in that category. And so we went through the whole process to be certified, and we were unanimously voted to move on in the process. And then CMS pretty much said, well, Medicare Advantage and other models we're testing can just incorporate Capable if they want. So, and there's been a bill in the House that was written in the Ways and Means Committee to make capable a Medicare benefit. And I do think it will happen in the next 5 to 10 years. But right, we need it now. And I think as more and more Medicare Advantages, Medicare Advantage is becoming a bigger part of the Medicare market, and there's nothing stopping Medicare Advantages from doing capable. But if it were a regular Medicare benefit, then it would count in a different part of their accounting, and it would make it much more affordable. If I don't want to get too far into the medical loss ratio and all of that, I'm happy to if people have a question about it. But it would be helpful for Medicare Advantage and for Medicare if it became a traditional Medicare benefit. So that's really what we're working on now. But at this point, it's still a state by state solution to try to get it into each state individually, which of course is slower. And it means that states that are less nimble and do less, creative things, those older adults won't get it there. So we don't see that as a solution.
Okay, thank you. And Cheney, you talked about there's this shift going on with money flowing from the nursing home situation and Medicare toward home care. Are you optimistic that's going to continue? Do you see funding problems ahead? What's your prognosis here?
Well, I think that I am optimistic that we will continue to try keep people in the community. But what I will say is that, one of the things that I have been really diligent about working and supporting is the direct care workforce. And without the direct care workforce, the system does not work. So whether you have dedicated resources to deinstitutionalization and allowing folks to live where they want to, somebody has to deliver the services. And so I think that we have to do a much better job of supporting them. And that can come in the form of increasing their wages. It could come in the form of providing paid leave. It could come in the form of, just improving their overall job quality. But yes, I think that the attitude shift is also is supported by what we see over the last 30 or some years. It's really had there are still states that, now it varies by state. There are states that are more generous with their home care allocations than others. But in general, I think the sentiment, and as driven by something like Money Follows the Person, is that there's an understanding that people want to age in the community. And so there has been support, but but the direct care workforce is really the backbone of a lot of that.
And
Thank you.
can I add to that? There's a model that's fairly new. I think there's just only one in Houston, and there's one being built now here in Baltimore called Care House, which is Care HAUS, where the direct care workers live in the same building as the people that they're taking care of with their kids or family, whoever's around. And then they're getting
Great.
equity in the building as the building, that's part of the model, is that it's not that they're eventually going to own the building. And so that helps with, their wages are still the same that they would be any other place, but they're getting kind of this pension in a way by being able to get equity in the building. And I think that, we need all kinds of models. We need an all of the above strategy.
Yeah.
Thank you, Sarah. We only have a few more minutes, really 1 minute before we're going to try to have questions, but do either of you have story ideas? What would you like the media to be writing about? The program you just mentioned might be a great thing to do.
I can
Sarah.
put it in the chat. I don't know if everyone can see the chat or.
Yeah, everyone can see it if you. And Cheney, you too. Any thoughts you have on what isn't being covered?
I do think that there has been some sounding of the alarms as it relates to the direct care workforce. I do think that we could do a better job of thinking about how the whole system flows together between the workforce and family caregivers, because they also often get, that label of doing informal care, which there's also contention about, because what does that really mean? They're doing the same job, right? And they're supporting one another, but they both are needed. If there's a family caregiver involved, the support is tremendously valuable. So I'll just say that.
Okay, great. Well, I think we could start some questions now. We're almost at that point. So anybody have any questions for either of these panelists or both of them that you want to ask?
We have one from Lisa. Let's, I'll help you with this, Carol. Lisa,
Thank
go ahead.
you.
Lisa,
Okay. Thank you. Thank you so much for this. I was taking tons of notes as you all were talking. I work in San Diego, California, and I focus a lot on homelessness. And one thing that I have been hearing about efforts to pilot here that's not been going so well is home health workers in shelters. This
Mm.
is a desperate need, and people in housing. And I'm curious if you've seen any models for something like this, if there are any communities that have done it, or you have any thoughts on how something like this could be done. Because the
Interesting.
homeless population is aging and people literally can't qualify to be in shelters because they can't do their ADLs. So they're stuck on the street
Mm.
because they
Wow.
also can't qualify for a skilled nursing facility. So I may want
Wow.
to talk to you both offline about this more, but
Right.
like, I was like squirming in my seat talking.
Well,
So.
when I was in nurse practitioner school, so I worked in healthcare for the homeless here in Baltimore before nurse practitioner school, and then in nurse practitioner, I almost didn't listen to the aging part. Like I became an aging convert later, because at that time there weren't older homeless people. There, at least in Baltimore, it was like there was enough housing for people once they were older that there weren't, or sadly people died. But it's so different now, and I know you all had a session with Margot Cushell and other people about that. I would say this isn't the same thing, but at USC in LA, there's a wonderful investigator named Ben Henwood, Henwood, who has adapted Capable for people who were formerly homeless, who are now in SROs or supportive housing. And he's had great results with that, even though, it's a very different population than we had tested. So I'll just put his name into the chat. I know it's not exactly what you were saying, but.
Yeah, and I've not seen strategies to support any sort of home health in those who are homeless. So you have my wheels turning just out of,
Yeah.
because wow. And I'm not well versed enough I know the needs, but I'm not well versed enough to really speak on it. But I do think that that's probably definitely an innovation that we need to think about in terms of either home health or some other sort of support that folks can receive.
Aisha,
Thank you so much. This is definitely my wheelhouse, so I appreciate everything that each of you has shared. I'm curious, this question is for Chani, and I apologize if I've mispronounced your name, but particularly with home and community-based services, Medicaid waivers and the like, and I think you were going to get into this a bit, but I'm curious to know what the primary barriers are particularly for communities of color in accessing HCBS, since this is something that a lot of people don't understand is not typically sponsored by Medicaid. I'm sorry, Medicare, correct. And so what tend to be like the top barriers to getting access to those HCBS that folks desperately need?
Yeah, one of the things that I'll say is that one big barrier in general is the waiting list issue that we have. And again, as preparing for today, I found an article in the Washington Post that talked about Maryland's 21,000 person long Medicaid waiver wait list from a couple of years ago. And so that's a big challenge. What's not in the research that I think is happening just from my own work is that it may not be that there may not be racial differences. Like you might not see disparities in the waiting list because people are just trying to get services. But I think that the impact of those have differential impacts on folks who are already really like either far along in their, disease or disability, that are already living with fewer financial resources and so on and so forth. In terms of other pieces and around accessibility, a lot of what I see has to do with language and the lack of culturally competent services. So a quick story, when I was a care manager, I had a client who had to go into a nursing home temporarily, and she was in there with one a CNA that could speak Spanish, and she was primarily Spanish speaking. So her quality of life was disrupted to the point that her family had to remove her. I also remember people coming far, from far and wide to go to a Spanish speaking adult day center, because
Mm.
that was where they would feel the most comfortable. They would come from a half an hour out to get to that one place. And when you don't have those services available, it makes it difficult for folks that are not primarily English speaking, or don't have English as their first language, to access and those services and have a good quality of life. And then the one other thing I'll say, outside of access, is that we know in like Medicare home health, that there are disparities in the services that people end up receiving. So, for example, some studies have shown that Black older adults the initiation of services takes longer for racial and ethnic minority groups.
Mm.
The number of services that they receive is less than their white counterparts. They receive different services, and so we don't really know the root of that. I think in Medicare home health, it has a lot to do with the quality of the agencies that we can measure, just with available data. But we do see that happening. And so those are just some of the disparities that we talk about when we're thinking about HCBS. And then the assisted living piece, tremendous, are really, there's a lot of underrepresentation with racial and ethnic minority groups because of cost and where they're located. They're typically in richer, whiter places.
Mm-hmm.
Jonathan, I think you're next.
Thanks. I had put a question in the chat, but to put it out here, I mean, is Capable, and this is for Sarah, I think, is Capable only available through state Medicaid or Medicare programs authorizing, or can it be implemented through some other organization?
Yes, I'm sorry, I was very unclear. I'm happy I could flash up a map if you want, but one thing that's interesting about Capable is all different kinds of places have started to do it. So in some places it's home health care agency with a Habitat for Humanity. Other places it's an area agency on aging. Other places it's a Meals on Wheels. There's several Meals on Wheels programs across the country. For example, in Austin, Texas, Meals on Wheels of Greater Austin. And the thing about Medicaid that's unique is if they pay the dollars, they receive the savings by not having people go to nursing homes. If you're a Meals on Wheels and you get you pay for an RN and OT, you're paying it out, but you're not getting the money back. So it's like the classic wrong pocket problem. But there's all kinds of community-based organizations that are offering Capable.
Jenny,
Is
just
it
flagging. Oh, I'm sorry.
I was just gonna ask, is there a map or some sort of direction of where it's available? Like I'm in
Yes,
Buffalo.
I'll put the website for Capable and it has a map. So hang on one second.
Great, thank you.
Sure.
Janie, I just wanted to flag for you, there's a question from Anita Snow in the chat that you might be able to answer in the chat on an online comparison of the Medicare home health services state by state. If you know of a resource, or we could get back to folks on that.
I don't know that I've seen one state by state. I've seen comparisons of type of quality or Medicare home health compare, sort of in a, not disaggregated in that way, but I think that I don't want to speak and say it's not available. I could look and see, or we can look and see, but Medicare home health compare is accessible to, families. I mean, it's just, and people who are interested in using home health.
Charlene had a question in the chat and I see that she's raised her hand, so I'm going to have Charlene go next.
Yes, my question was related to Medicaid assistance for family caregivers. Is there a resource that shows state by state assistance, how much caregivers will get paid hourly for their services in that state, or what Medicaid services or what Medicaid programs are used to pay family caregivers by state?
Yeah, so most states have sort of matured to allowing family caregivers to be paid. It was not always the case. When I was a care manager, you had to do a strong justification for a family caregiver to receive payment, especially if they had already been doing that care, like providing that care. They are provided payment through self-directed waivers. So in situations where the person, the older adult or the person with disability hires them as their caregiver, and then they are paid that way by the state. And I'm trying to remember your other question. You were asking if there was like a list of like state wages and things like that?
Yes, any state by state comparison tool on pay for their family caregivers.
I've seen one in my own research that was preparing for a talk a few months ago, and I saw one that I can find and share. I didn't fact check it, so I can't guarantee that. I have to go back and look and see where it came from, but I did see one. There was one that provided like states permissions in terms of wages, but if I find it, I'll share it.
I wanted to ask both of you if you could just talk briefly about the whole crisis in caregiving services, which the whole ability to stay at home depends on this. And where are the shortages most acute? Is it nursing? Is it PT? Is it handy people? Is it all of the above? Are there any models that are addressing this well?
Well, I think Cheney will have a better answer than I will, but I'm just going to jump in very briefly since you mentioned nurses. So I'm the dean of a nursing school, and there's one nurse for every 83 Americans, which is actually probably enough. You know, people talk about the nursing crisis, the nursing shortage. We just have much too far we're too far on the spectrum of acute care instead of preventive care. And we are developing here at Johns Hopkins, along with Morgan State and Coppin State, which are two historically Black colleges and universities, and University of Maryland, a door-to-door neighborhood nursing model with nurses and community health workers to try to get us much farther towards that prevention side. It was like the health visitors program in Britain, or like probably some of you read about Costa Rica and their program, but so it's geographic based. It's not based on people's insurance or their age or their diagnosis or whether they've been in the hospital or not. And we're going to leverage the fact that in Maryland, all the payers, all the insurers work together to pay for hospitalizations. And we're standing this up so that the next level of the waiver will be for population health. And we do think that this will help with aging in community as well, because it will, will catch chronic conditions earlier and check in on people in terms of social support. And the community health workers will be able to do cognitive behavioral therapy and also PTSD treatment. So I just wanted to put that out there in terms of a preventive model, but Cheney would know much better than I would about the home care, the direct care worker part of your question.
Yeah, I think that, we're short everywhere. I think, in terms of when I talk, I think I mentioned that there's the home care workforce, the residential care workforce, the nursing assistant, the nursing home workforce. I think they all deal with their own set of challenges. Much of it is tied to, and I think Aisha was the one that put in the chat that the challenge is aligned with the shortage of home care jobs with livable wages and access to benefits. They're not jobs that are sustainable, right? And so, like, we did a survey in Maryland that collected information about the home care agencies here, the non-Medicare home health agencies, and so these are private pay and Medicaid home care agencies. And a couple of questions we asked were specifically related to COVID, but what were some of the things that prevented these administrators from supporting, like what were some of the challenges they experienced in supporting their direct care workers? And a lot of these agencies, and you have to realize that they don't all look the same. Some are very small, right? And then some are huge. So they really vary in terms of their resources. So some of them they didn't have people to, substitute if a person couldn't come to work because they were taking care of a child or they were sick themselves. they did not have paid sick leave available. And so your job is compromised if I have to take off time to take care of my own family in a pandemic, right? And now, you know, even moving on past 2020, but there were, and then, you know, the wages issue was also challenging. A lot of that is due to Medicaid reimbursement for those agencies that are Medicaid funded, is that there's only there's only so much I can pay you if the reimbursement is not providing enough. But there are some strategies that were used during COVID to help support the workforce. That is the increase of wages in some places. I think most states at least tried to increase wages in some way, shape, or form. The exact dollar amount I'm not sure of, but the sustainability is really, really, really challenging. And that's on the provider side. And then of course there's the job quality piece around safety and, you know,
Right.
being people's personal space and homes and everything, and training, right? So a lot of direct care workers receive minimal training for their roles. And so they're not always prepared. Their intentions are good, but they're not always prepared for the scenarios that they walk into. And so those are some of the challenges that we face, but, you know, we need them. So we have to treat the ones that we have well, so that we can continue to build and strengthen that workforce.
Thank you.
I'm gonna let Lillian ask her question, but I wanted to refer everyone to Paul Nagel and his Stonewall Bridge project, which was really meant to address the workforce scaling of LGBTQ caregivers. So that's an interesting model if it comes online, sharing houses to provide housing and undergird the training of the workforce. So Lillian, you've been patient, over to you.
I was taking notes. If this was mentioned and I missed it, I apologize. Has AI been looked into as like something to help with? I know that at the beginning, Sarah said something about, you know, like a lot of old people living with their doors unlocked because they're not sure they're gonna get, you know, let anybody in or whatever. AI, like just any assistive, right? So just out there right now, is this being looked into? It could really help with like alleviate some of what the workforce has to do. Is anything kind of being explored there?
Go ahead, Janie. I've got something to say, but go ahead.
I think that so there has been technology that has helped. So for example, when we were social distancing, right, during the COVID-19 pandemic, and a lot of adult day centers could not be open. Some of them provided virtual activities for folks. So that was a way for people to stay connected. We know that telehealth and other sort of technologies sort of ramped up during the pandemic because people couldn't be in close contact with folks a lot of the time. We also see in rural communities that that's effective as well. I think that there's probably, my take is that you still need a person, because a lot of the activities that a lot of the benefit of home care is, yes, the provision of, you know, meeting your needs, bathing, dressing, things like that. But a lot of it's also the social contact element. And people really benefit from having the extra eyes in their home and the extra support, you know, and we know that because one of the things that that HCBS, in addition to supporting people at home, strive to create is that social connection, to improve people's social connection and their ability to participate in the world in a way that they want to. And so I think that there are probably some things that we have Meals on Wheels, right? So we do have ways to provide people with food and things like that. We have medication reminder machines that'll spit your medication out, right? So we do have some technologies, but I do think that there are obviously benefits to. I don't think everything's going to be able to be replaced. That's.
And
Thank
I
you,
would
Shanae.
add-
Sarah,
Sorry.
sorry. Thank you, Shanae. Sorry, I just wanted to put into context that I'm not talking about replacing people as much, but just like as assistive and like if it's just being explored.
Yeah, so there's something called PI, which they're calling personalized intelligence, I think. So if you think about Alexa or Siri, and hope they don't wake up, those are factual, like when does this movie start? Or can you set the timer for 10 minutes? Or and a lot of older adults use those, but they're not learning from you. And very soon there will be, and in fact, there already is one that's very conversational, but that learns from you. So you say, oh, I had a problem with my daughter and I can't believe it. And it says like, oh, sorry to hear that. But then it's remembering the daughter part. And it may ask you the next day, how did it go with your daughter today? Or, and that, again, this will not replace humans, but I think there are many people who think that in the next phase of artificial intelligence, we will all have a coach, a companion, a person who's like friendly and knowledgeable, and they're not quite a therapist, but they can listen therapeutically. And you all probably know that there's this famous study where a psychiatrist sent out letters to people randomly assigned who had tried to commit suicide. I think this was in the 50s. And it was random. And of the ones who just got a letter saying, I'm thinking of you and I hope you're doing okay, there was like a lower bad outcome rate among those people. Like, it doesn't take much as humans for something to impact us to say, oh, I was thinking about you today. And so I do think that even though obviously machines will never replace us, there is some room for a personalized learning, so-called intelligence for older adults, not to help with bathing and dressing, but to be, provide some sense of companionship, even though that sounds kind of gross to say it.
Thank you.
Any other questions? Did anyone have a question in the chat that you'd like to ask out loud? I have a question for Sarah. I'm really interested in how Habitat for Humanity embedded the capable model. And I wondered if you could talk a little bit more about that partnership and how it helps scale and
Great.
just generally working with Habitat.
Well, so Habitat is wonderful. Anyone who's worked with them will say that they're one of the most decentralized groups you can imagine. So there is a so-called Habitat for Humanity International in Atlanta, but they can't tell anyone what to do. They're of the local. So it's not like, the Boy Scouts or, other kinds of things where there's like a top down. So if, just like the saying they say with foundations, if you've worked with one habitat, you've worked with one habitat. That said, they, a lot of them are very fierce volunteers who, come to it with their own views of like, don't tell me what to do. This is what I'm doing. That said, they're fantastic. They're all over. They're different sizes in different places. And so we've let like the Habitat for Humanity International, the group in Atlanta, kind of wrangle the sites and say, okay, you get together a group of, 8 sites and go in together for a grant. And so some habitats have gotten support themselves, and they have a whole aging, they call it aging in place, kind of part of themselves that generally is just like grab bars and fixing holes in floors and things that are really important. But then at least probably 20 at this point have come forward and added capable as well. And it